Okay, so welcome everybody in the room and those of you that are online. Hopefully there's some because I can't see from here. So we're in Seoul, which obviously the ones in the room will know. We run and have run for quite a time at SNOMED meetings, clinical webinars, where we invite clinicians to come along and talk about their use of SNOMED, essentially. So their experiences, hopefully for good, but also for bad, and things, have a bit of a discussion. We have two presenters, which I'll come to in a second. The one thing I would encourage you all, we're going to allow some time for questions at the end. So please save up your questions, but we will answer them. And if you don't come up with some questions, myself and my colleague will. So these two presenters won't get away with it. I've put this really a bit, just to give you a bit of background. So those of you who don't know me, my name's Ian Green. For the time being, ignore what was in the plenary. I'm still working full-time for SNOMED at the moment. So one of my roles is the Global Clinical Engagement Lead. So I, with my colleague, Dr. Charles Guttridge, who's at the table, and my other colleague, Jane Miller, who isn't here, who's not in Seoul, but the three of us try to really drive the clinical agenda and get clinician engagements, get clinicians involved in SNOMED to encourage you where we can. The vision is on there. I'm not going to read the vision. You can read that for yourselves. But the real kind of emphasis for all three of us when we talked about this, talked about clinical engagement and driving this forward, is the acknowledgement that SNOMED itself is a clinical terminology. We rely on you as clinicians to input and tell us how SNOMED needs to look, particularly when you take into account that medicine and healthcare develops and changes over time and changes quite rapidly. SNOMED covers all of healthcare, so for us internally to try and keep that up to date is impossible without your help. So please help. I've put a link on there. You can have access to the slides afterwards. And also this session has been recorded, so you can watch it again. You can share it amongst your friends after. But the link on there will take you to a page on Confluence, which is the platform that we use to share documents within SNOMED International. On there are links from that page, are links to other pages for all the previous webinars we've done. The webinars include all the slides, but it also includes all the recordings from previous ones. So I'd encourage you, when you have some spare time, which I'm sure is all the time, please go there and have a look. But bringing us on to today, so we have two presenters today. I'm going to let them, they'll give you all their backgrounds themselves. I'm not going to steal their thunder as such. There's Professor Jungchan Park who'll present first from Korea. He's going to talk about anesthesia and Korea's experience around implementing SNOMED with anesthesia. And Dr. Ismat, I can never say your last name. It's just Ismat, right? So Ismat, I've known for quite a long time, from when Malaysia became a SNOMED member back in 2012. But Ismat's going to talk about really the journey that Malaysia have gone through in terms of work they've done with cardiovascular and also work around dentistry. But without further ado, I'm going to hand over to Professor Park. So over to you. We're looking forward to it.
Thank you for the introduction, and thank you for coming, and also thank you for having me here today. It's an honor to be a presenter here. I hope you guys are having a wonderful time in Korea. I am actually, my name is Jungchan Park. Hi. I work for Samsung Medical Center. I'm actually a full-time clinician in the Department of Anesthesiology. So my job is like full-time anesthesiologist. But while doing that, I have my PhD in medical informatics. So I've conducted several studies using common data models. Those experiences have provided me this idea that the standardization of terminology is how important that is, how important to standardize the terminology in anesthesia. So recently I've joined the task force, which is organized by Korean Society of Anesthesiology. We have organized task force to standardize terminology, and our ultimate goal was actually to adopt the terminology into the common data model. So today I would like to share our experience from the task force of KSA. I have no conflict of interest to declare. The first, I would mention the background. The reason why we're trying to standardize the terminology associated with the anesthesia is that any surgery, it covers an enormous field of medicine, because any surgery that needs anesthesia, we have anesthetic records and anesthetic data. And actually there's like over 2 million cases of major surgery in Korea annually, and there's a need for standard anesthesia record. And we think that our final goal would be facilitating the data sharing and improve the patient care by standardizing the terminology. I would like to start with the unique aspect of the anesthetic data. First, it's very broad and complex. It covers various types of surgeries, and they have vital signs every 5 minutes, so it's broad and complex data. However, it is at the same time, it is very compact, because anesthetic data collects the data specific time while you're doing the surgery. So it is a very compact data. These are the components of the anesthetic records. It covers from the pre-anesthetic, pre-operative period to the operative times. We collect mostly the massive data from while the patient is receiving a surgery, but we also cover the data from the recovery of the patient. And if we take a wide look, the postoperative outcomes and the complications of the surgery is, we could say that they're also included as the part of anesthetic data. These are some unique aspects that the anesthetic data have. They have the ones that are different from the other medical data. First is multimodal. We have data coming from the various sources. It could be vital signs. We record what drugs we've administered. We also record the main event during the surgical event. And we have an anesthesia machine. And we also have, nowadays, we have more and more devices that collects the hemodynamic parameters. And like these are the signals that shows how deep the patient is sleeping. And it also has a very high granularity. As I've said, we have vital signs from every 5 minutes. That's so much more than the vital signs from the intensive care unit. So we have a very high granularity data. And because it has a very high granularity, it also captures the subtle change, little change of the vital signs. Then the drug would be immediately administered. And it also reflects the response of the patient after the drug administration. I don't think my clicker's working. Can I go back? It's going forward. Can I? Yeah, backwards. Yeah, thank you. So the anesthetic data is also very temporal, because it immediately reflects the change of the patient, and it also reflects the clinical decision that anesthesiologists have made in the surgical field. And it is also it has a very high interconnection, because what it means is that if the vital signs of the patient changes, then drug is administered, and then the vital signs changes back in the response of the patient. So understanding this relationship is pretty important. So the professional anesthesiologists are to be highly involved while standardizing the anesthesia-related terminology. it's working back again. These are other unique aspects of the, it could be noisy. These devices in the surgery room, so it could be noisy, and it's very critically time sensitive, and it data, and it only deals with a specific period. We have organized the task force to, we have approximately involved across over 10 university hospitals. We have a clear objective is to develop a standardized medical terminology set for anesthesiology. It is closely related to the safety of the surgery and procedures, and we aim to ensure interoperability between medical professionals and healthcare institutions. Additionally, we aim to expand the foundation of medical terminology and apply it to international standards, and we hope to use this as an international standard in clinical practice. For specific goals, we're now developing standardized terminology set. We are strictly focused on the frequently used terms in the anesthetic process. And we also want to ensure the interoperability between the institutions, and we want to ultimately want to facilitate communications regarding anesthesia practice with other medical institutions. And we want to increase communication between anesthesiologists and surgeons through standardized terminologies. So what we're doing is we're developing a mapping table between the standardized terminology set and SNOMED CT. So for the concept, including the standardized terminology set, is from the SNOMED CT reference set as a priority. This is a schematic form of how our task force's work is going on. We first made the expert task force, and we analyzed and selected the current terminology. And we defined the terms and ensured consistency. And the experts in the task force are discussing and reviewing the terminology. And now I think we're at this stage right now. We're developing a standardized terminology data set. I think we're about to finalize this database. And after this, we are planning to promote and educate this and maybe turn this into a common data model and continuous updates and improvement. While selecting the current use terminology, we reviewed the anesthetic record forms because anesthetic record forms are pretty much similar between the centers, but they have little differences in the detail, especially in the era of electronic medical record system. Each hospital may have different anesthetic record forms. So we're gathering the anesthetic record forms from over 10 university hospitals in Korea, and we're discussing and selecting the frequently used terms from the electromedical records anesthetic form. So these are the example of some anesthetic records in the electromedical records. They may be similar. They contain vital signs, pre-anesthetic records, and everything, but the details may be a little different from the centers. After choosing the frequently used terms, we wanted to use the terminology set from the SNOMED CT rather than EDI or KCD because we chose SNOMED CT because we supposed that SNOMED CT was most field-specific terminology that actually use the term that actually contains the terms that are actually used in the clinical practice. While the EDI or KCD has a terminology for the anesthesia fees, but those are for the bills. So we chose SNOMED CT because it's mostly related to the clinical practice itself. So we chose the concept in the standardized terminology set. We revised and refined it with the terminology expert then we reviewed it again with the anesthesiology expert. And if it matches, then it goes into the final mapping. And if it does not match, it goes back to the terminology and revisions, and it goes through revisions and refinement until the anesthesiologist expert actually agrees with that. So in the concept in the standard terminology said we wanted the 101 match from the SNOMED CT, and if it matches, it perfectly matches with the pre-coordinated SNOMED CT, then it was added to the Korean representative terms and synonyms as new description in the Korean edition of SNOMED CT. And if it did not match, then we used the post-coordinated expression in SNOMED CT, and if it matches from the post-coordinated city, then we added sources to the Korean edition of SNOMED CT by modeling them as a new concept. And if it still does not match, then we added the necessary concept for the post-coordination modeling. So it's standardized terminology database. We developed the standardized terminology from the reference set. So from the subset to the reference set. And we grouped the anesthetic data into 7 groups. It included anesthetic agent, monitoring, and anesthetic techniques, and pre-anesthesia evaluation and baseline characteristics of the patient. And we also had the procedures, and we also had the vital signs, and we included the recovery records. So for the anesthetic agent, anesthesia it requires several types of agent. The unique part is that we also use an inhalational agent. We don't use per oral drugs. We use IV or the inhalational agent. We use drugs to put people into sleep, and we use drugs to relax the muscle. So these are all different types of the drugs. We need to cover all different of types of the anesthetics. For the monitoring, we have a lot of systems of monitoring. The unique part about the monitoring is that nowadays they're coming out with new techniques, new devices to monitor a lot of stuff. There are monitors that specifically reflects the pain of the patient or sympathetic tone, and a lot of new hemodynamic parameters, which are golden standard, or some of them are just on a test and they just disappear one day. So how deep are we gonna standardize the terminology? It was the main question of the task force. We have gone through a lot of discussions. For anesthetic technique, it is also tricky. It was the most tricky part actually, because for the anesthetic techniques, there's only like broadly there's only general anesthetics and regional anesthetics or like local anesthetic. But if in the same general anesthesia, people can be intubated or they could be non-intubated, or if they're even in the patients who are intubated, there could be other types of devices for intubation. So and anesthesiologists are pretty sensitive about what devices they use for the intubation. So these, how deep we should go in and how much of a granularity that we're gonna provide with the standardized terminology, it was a big question. I think this is the final part that we need more discussion, and this part is still, we're working on it. Pre-anesthesia evaluation and baseline characteristics, I think it is pretty similar with the other field of medicine, so not much to say about this. And procedures, we have a lot of procedures. We intubate patients. We do the regional anesthesia we could use sonography, or we could do it with the blind technique or the nervous stimulation system. So like using a different devices is still a question. And vital signs, yes, like I have said, there are new parameters of the vital signs. Hemodynamic parameters are still developed. There are a lot of stuff under development. So it is the field, I think it needs most update afterwards. And for the recovery records, how well patient can recover, but like different institutions have a different standard for the full recovery. It could be just walking, and for nowadays, the concept of ERAS, enhanced recovery anesthesia after surgery, is a new concept that is very popular. So recovery records are becoming more and more important. So we are paying a lot of attention to the recovery records too. So as conclusions, we are developing a standardized terminology set focused on the frequently used terms in the anesthesia. We want to lay the foundation for the standardization of anesthesia-related medical records. We think this could contribute to the sharing and utilization of surgical patient healthcare data. So we are expecting some of the outcomes. It could be clinical benefit from the clinical benefit perspective. It could be the foundation for standardized anesthesia records, and it could ensure consistency and improve communications among healthcare providers. I think it would facilitate reuse and reanalysis and data sharing. It would ultimately promote research and data analysis and patient-centered care. And I think it would enhance patients' understanding and enabling personalized healthcare system. From the research domain, I think it can enable nationwide research use. It could improve anesthesia education and knowledge. I think it could also enhance expertise, safety, and it could strengthening the global collaboration and standards. The future direction that our task force is we're looking forward to is we're going to continue to develop and finalize the standards terminology set. We want to contribute to the clinical research and data sharing and utilization. We want to establish a database, promote and educate, and provide continued updates and improvement. And we want to propose new items for expanding the designation of the Korean core data interchange. So thank you for your attention.
So we have time. Do you have any immediate questions? This is to the audience, not to you, Professor Park. Does anyone have any immediate questions for Professor Park? I thought you might.
Thank you. It's an excellent presentation. Thank you very much. I'm sorry.
No, okay.
I see you look this way, and we were in the same line. Sorry. Sorry. Well, thank you for your presentation. It's excellent. I wonder if you can comment about the model that you're using behind this research, because probably you have like a form with fields that you need to complete, and you select the right concepts to fill out these things. It's a standard form. It's something that is adopted from some other organization, or is a local form for Korea or something like that?
Actually, we're collecting the frequent use terms. We did it by hand. We had a discussion between the 15 members of our task force, and after the finalizing the set of frequently used terms, then we went into this SNOMED CT and found the pre-existing terms, and if it were not there, we coordinated the pre-existing terminologies, or if it was not possible to coordinate anything, then we would just suggest a new concept.
But in your clinical use case, you have like a form that you need to fill with all the details of the anesthetic procedure, with different observations and things like that, right?
So yeah, we have a standardized form from each center, but the form would be like different. They're pretty similar, but very different from the center to center. So what we did is like we collected all the standardized form and made a new, listed up the frequently used terms or the common terms that are all present in all the forms of the anesthesia record.
Thank you.
Yeah. Go ahead, Charles. I'll take up to you.
No, you go first.
You want to go?
You go
You want to save that question for me then? Thank you, Prof. Park. It's very nice, very exciting to see the work. I've just shared some of the photos with my anesthesiologist friends. In case they're interested, they might be contacting you. My question is actually about when you talk about data exchange. I'd like to know what is your motivation or the reason why you want to exchange that data. Is it, for my part, sometimes we talk about reporting, sharing reports, but is it about like, do you need to send patients to another facility where you need to exchange the data? I'd like to understand your use case.
Oh, exchanging the data. When we are sending a patient, the patient records are also transferred, but in a different form. So that was actually, frankly speaking, that was not our original purpose. Our original purpose is mostly focused on research area, because like the surgical data is if you have like one surgeon in our center, we have one surgeon only for one surgery. So the data might be biased from the one single center data might be easily biased. So we wanted to have this nationwide data. So exchanges, we want to standardize terminology first and then map this into the common data model, which is an open access that it is widely known. So I think research purpose was the main reason we started this task force.
Thank you very much for your presentation. There are a few things I'd like to just explore further and also get clarity. The first question really follows on from what Alejandro asked, which is the collection of data in workflow within your electronic health record, or is this a data collection that the surgeon or the anesthetist makes after the procedure?
What do you mean, the recovery records?
What I'm trying to find out is at what point does do the doctors in charge here collect the data? Is it as they are working within the electronic health record, or do they go back to the record with the form?
We go back to the work mainly.
Yeah. Okay. So my next question is, there's obviously a very strong focus on the anesthetist role, but I think most operating theaters is a very multidisciplinary environment with an operating department assistant or maybe two assistants, and then an operating room nurse and maybe other nurses and so on. Are they part of this, or is that yet to come? How do you see other professionals in the theater contributing to the data collection?
First of all, what I would like to mention is that there's not a single data that fully reflects the situation in the operating theater. Operation notes, they reflect a lot of things during the surgical procedures, but they do not reflect anything from the anesthesia. But anesthesia records, we do have we do not have a full detail of the surgical procedures, but we do have records for the main event, like massive bleeding, or like some kind of like those data that are related to the surgical procedures. So because this work has been started by the task force from the Society of Anesthesiologists, we are starting with anesthesia data. We are trying to collect everything from the anesthesia, which also has details on, not a detail, but the main event from the surgical field. So I'm not sure whether we are going to extend this to the surgical notes or not, because all the surgical notes, they have a lot more disparity from the departments where patients are getting surgery. So I'm not sure whether we can get there or not, but we are now about to finalize the anesthesia data. So I don't know, we will probably talk about expanding this to the surgical notes.
One last question, if you can bear it, is what sort of education, training, learning have you provided for those anesthetists reviewing their own terminology or their sort of local terminology and the mapping to SNOMED? Have you done special courses, or how do you expect anybody to understand?
That's a hard question. I wouldn't say a course, but we had few days of a lecture from the terminologists and from the ones who had the. Well, I have my PhD from medical informatics, so I was pretty familiar with the standardization of the terminology using the data and like those stuff. But a lot of anesthesiology, other members in the task force were not. So we had some lectures, but we did not have any regular course, and we are actually looking forward to promote those chances for anesthesiologists to have an education on medical informatics, get some ideas on standardizing terminology and interchanging the data and how the data are handled. We're looking forward to that as from the Society of Anesthesiology.
Thank you very much.
So I don't have a question. I have more a comment. I think I mentioned in the plenary session that we, under the clinical engagement banner, we have some clinical reference groups, one of which is an anesthesia group. The members of that group currently are European and North American, but I think it would be a good exercise to share the work you're doing with the anesthesia group for two reasons. One is obviously to do what we're doing here. So one is about sharing the work that you're doing, which is in everybody's interest in one sense. But in terms of the one thing that you touched on about the content within SNOMED, I know that we have changed a fair bit of content within SNOMED over the years related to anesthesiology as anesthesiology moves on itself. It would be good to get some of that detail and look at the actual content within the international release, because some of the, I'd be surprised if this isn't true anyway, some of the content that you're looking to use, which currently isn't in SNOMED, I would suggest is not uniquely Korean. So, you know, it's content which would have international utility. So we should really be looking at really adding it to the international release. So it's my invitation, if you like, to you to come and share what you're doing with the anesthesia CRG. And I know where you live, so I'll come and chase you. So thank you. I'm sure we might come. Oh, we've got some. Oh, hang on. Oh, hang on.
Yeah, Victor and I work with the anesthesia CRG at SNOMED International, and so we're interested in this. It's a great endeavor. Really love the idea. Would like to share it and like to actually get our eyes on it and have a look at it. Do you have it as a data set that we could look at?
No, not at the moment. I'll share it with you.
And also gaps, you know, things that you couldn't find that you did the post coordination for, etc. All of that would be interesting.
It's mostly the new devices, because anesthesiologists are like really sensitive about devices. If you use the different devices, we take it as a different procedures.
Yeah, we've been trying to do some work on that with using the ISO standard for ventilation, but it's so complicated. It's not been an easy task. So and that would be really something we could work on too. So thanks.
And I think also combining those concepts is a really, I think it's the best way, because like creating new concept is a difficult task, but by combining the concept, like coordinating, I think it would be the better way to express like all the data we have.
I have a question about the preoperative conditions of the patient. I know that some conditions may trigger some alerts on your work or risks. Have you also standardized those terms on to just create that alert if the condition is known?
Yes, we're doing that because I forgot to mention those, but there are specific alerts that anesthesiologists are very sensitive, like the airway difficulty, looking for the difficult airway, or the allergic to some food allergy could also be dangerous. And malignant hyperthermia is the worst. I don't even want to mention it. And then any risk, cardiovascular risk, is also a risk that we want to prevent. So we are standardizing also the risks that we have it on the pre-anesthetic record form, and we're standardizing that too.
Yeah, good.
After reviewing your terminology and comparing it with the hierarchy of anesthesia and SNOMED CT, how different are they?
They were not that different. We were just, they were not that much of a different. No, I don't think it was very different.
Okay.
It was using snow. I think choosing the SNOMED city was probably like the one of the best choice we made after creating the task force, because we chose SNOMED city after after organizing the task force. The task force did it. It was not actually organizing task force was not targeted to use SNOMED city.
Okay.
We chose the SNOMED city, and I think it was the best choice.
All right, thank you.
Okay, let's move us on. So, Professor Park, thank you so much.
Thank you.
And I'd like to invite, I'm going to get it right now. I'm going to invite Ismat Sulaiman. Good. Okay, my pronunciation is getting better over time. So I'll let you introduce yourself and talk about Malaysia.
Sure. Okay. Thank you, everybody. Good morning. Let's go on to the, everything runs. It changed. So thank you for the invitation, Ian, for this talk. I thought that we can start with the overview of what Malaysia is, but also as a continuity with Prof. Park. I remember when we started, we also started with the registry. So it's very focused. I think it's a pretty good step where you want to, launch forward. I see it as utilizing SNOMED CT as in two parts. The first is about standardization of clinical terms, and that can be, of course, used for data exchange. But on the other hand, we also look into using SNOMED CT for data analytics. So as part of my story, I think I would say that I take on the second part, which is data analytics, and I think it's a good session today to have that overview. So I think I can skip this. I did present this yesterday with the member forum a little bit. This is just a bit more on the clinical side. We have about, so Ministry of Health Malaysia, we are a dichotomous healthcare system. We have the public sector and the private sector. But our public sector caters about 70% of the citizen or the population in Malaysia. And you can see, even though there are more private hospitals, but the coverage for the beds, we have more of that. So when we started, we actually started in So we started in 2009, but we actually became a member in 2012. During that time, we had just like a session like this, a bit smaller. We were discovering where we could implement SNOMED CT. And that is where we discovered that instead of implementing at the front end, which is what we call the front end is mean by our electronic medical record, we decided to implement it at the back end, which is at the stored data already. And the reason why we did that is because we didn't have actually nationwide EMR. At that time, there was about 10%, 12% of our hospitals have electronic medical record. Those EMR are mainly proprietary and in ongoing contracts. So whatever there's no legislation to actually enforce using SNOMED CT. And whatever changes that we impose on the running of the EMR, we're afraid that it might, invalidate the existing contract. So because of those challenges, and because we don't have the IT skill, we are very dependent on vendor when it comes to implementation. We decided to work with what we have. And what we have is actually secondary data collection, right? Because we work on the secondary data collection, we figure out how to actually benefit our clinicians. And one of those is actually gathering data for research or indicators, quality indicators. right? Usually at the ministry or at society, they like to do registries. And the registries is where they want to either produce research or they want to monitor the quality of services that they provide for the patient. So we actually took on that approach. See what else did I see there? Right, so at that time, this is quite new approach. We spent the first 1 to 2 years to actually create the reference set, the mapping basically. So just like what Prof. Park's team did, that's exactly how we started. We look at the terms in our cardiac registry. Why we look at the cardiac registry is because we know cardiac registry basically nationwide, and not just nationwide, but internationally, they all look the same. They collect the same information. They usually reflect each other. So we wanted to be able to not just create for our country, but also if we can facilitate other countries as well when we do the mapping. So we started off with the terms in the registry. And the following year, we expanded the mapping database or dataset to include all terms related to cardiology. So from 600 terms in the mapping table, we actually created a ref set that goes up to about 10 times the number, 6,000, all those related to cardiology. For example, diseases that is related or somehow comorbidity to heart problem like diabetes, all that. That's why the list of terms extended from 600 to 6,000. Right. What else? Right. So for this project, we actually, it's a tripartite arrangement. The tripartite arrangement is because we work with the informatician, which is us, or basically the people at NRC. Number 2 are the clinicians, because they are the one who sets what are the questions that needs to be answered, what are the terms, and they do the validation. And of course, our ICT engineers who develop the tool to actually code the terms, right? So that mapping tool, the implementation of that mapping. And that tool is what we call now as MyHarmony. Why MyHarmony is because it harmonizes the terms and also codify it to SNOMED CT, which I will explain to you a bit more compared to what I presented yesterday. If you want to look at the video, we have videos. You can take a picture and then maybe you can watch later. It's in YouTube, so sort of give an overview what MyHarmony tool does and what how it progressed from 2017 to 2019. The number just changed. But I think this slide will be made available in Confluence, so you can download it. Okay. So previously we talked a lot about the strengths, but this is where I want to share with you our lesson learned. The thing that we sort of slipped up on our part. When we developed the MyHarmony, we were excited and the clinicians were excited to use it. We were producing, our intention was to, when MyHarmony, what MyHarmony does is to actually automate the codification. So if you remember, ICD, you have to do manual coding at the back end, right? If you implemented EMR at the back, there's already a direct mapping. But when you have existing data already available, you cannot change or choose what terms the clinicians used. You have to have that type of data. You have to use it. So sometimes we have to add synonyms, our local synonyms, to our mapping table, to the existing SNOMED CT, so that we can actually harmonize and codify SNOMED CT. Okay. Unfortunately, I would say that the year that we actually tried to improve our MyHarmony tool to improve the process, we sort of lacked the clinical engagement side. And I'm afraid that kind of like slow us down in terms of engaging back with our clinicians, because we have to remember that they are actually the driving factor. It's part of the team. So I think that's part of our lessons learned that I want to impart to you today. So don't forget them. Once you have the tool and the terminology, we also need to get them still stay on board with us. Okay. Moving after 2019, there were works that being done to implement SNOMED CT at the front end, so at the clinics. So this is what we were waiting for actually. In 2012, we've already had a national agenda to actually implement EMR nationwide, but because of the progress is slow, that's why we took approach of the data analytics. But as the years progress, we can see there are more implementations of electronic medical record in the hospitals and clinics. And in 2023, I think there were about 50 clinics that have electronic medical record with SNOMED CT inside it. Because the others, we have about 3,000 clinics. 1,000 one-third of it is like a more comprehensive clinic that provides provides laboratory and x-rays, and those are the clinics that we target to implement electronic medical record. There are EMR that are proprietary that doesn't have SNOMED CT, but these 50 are the starting point where there is a SNOMED CT inside it. But I think the people who actually purchase or procure this electronic medical record at the clinics, they only know that SNOMED CT is behind it, but they don't actually know or think about how it can really benefit them moving forward. They didn't really think about, data exchange. They didn't really think about data analytics. They know that it's already been standardized. So I think by next year, in 2025, we're going to engage with them and see how we can actually utilize and improve, see where it can lead us to use SNOMED CT as a data analytics. And lastly, this year, actually, we in international patient summary. And what we use it for is actually for those people who goes for Hajj pilgrimage. Every year, Malaysia, let me see. Yeah, so every year, Malaysia sends about 30,000 people for Hajj. And we also send about 250 people, a team of medical team there to support for our citizens who seek care during the pilgrimage. So it is actually an extension to our existing personal health record, which is called MySejahtera. MySejahtera was actually developed for COVID, for detection of COVID, for notification, for telling people where are the surrounding area that has high cases of COVID and so forth. But as the COVID dies out, we need to find ways how to utilize the existing app. Right, so one of them is actually to implement IPS in the app, and it really helps those carrying that medical record with the patient when they go abroad and across border. Okay. I think I'll just run this over. This is an overview of our national strategy, what we want to do going forward. Actually, in last year, we actually tabled in the cabinet for a healthcare reform, and that has been approved. And that approval means that there are a lot of changes coming in Malaysia, and one of them is about digital health. The reform is quite general. It has 4 pillars, and one of them is actually about the technology enhancement to support the different reforms. Right. I wanted to share with you the overview or our ecosystem in Malaysia, or at least in the Ministry of Health. We have multiple systems. We have some are still in silo. We do try to get this connected. What I'm trying to explain to you is actually the yellow part. It looks small, but just imagine the summary of or a snapshot of all patients who visited our clinics, a snapshot of our patients who visited the hospitals will eventually go to our system for planning and decision making called Malaysian Health Data Warehouse, and that's what I want to share with you today. A bit more. Do we have time? So the Malaysian Health Data Warehouse takes into account the visits and the encounter of patients that goes to our clinics, hospitals, and even some private hospitals. Why is private hospitals want to be in? One, it is legislated, but we haven't regulated yet. It is in our legislation for them to actually send summarized data, but it's not being regulated. I think right now, about 40 to 50% of our private sector are sending in that data, either through general report or through granular line by line granular data. So we have this actually in our Malaysian Health Data Warehouse, and what we intend to do in Malaysian Health Data Warehouse is actually to produce all the reports and the KPIs and indicators that's required nationally and also internationally. One component that we have talked before is the MyHarmony. So MyHarmony not just look into the summary, we took in the discharge summary. Those discharge summaries that are usually written in a blob of text and unstructured or at least semi-structured data. And that is where we pumped into MyHarmony to actually make it into a structured data. And once it is structured, then we can actually produce reports. So this is the same QR code. You can see here what MyHarmony does is actually look at that discharge summaries, or not just discharge summary. We are also looking into laboratory reports and radiology reports. Those are that in text-based form, and to capture those pertinent clinical information so that we can actually produce some reports. Let me see if I can, something like this. So for example, the use case that we have is cardiology, right? So cardiology have at that time, we have about 8 KPIs, indicators. One of them indicators are, I think, non-ST elevation MI case fatality rate in different months, and we can also table out in different facilities. So if different facilities have certain KPI, we can do that. Also, another example is not ST elevation myocardial infarction without shock case fatality rate. So I think these are 2017, 2018. So I had this snapshot to do validation with the clinical team. So to actually look back, does this data make sense? And of course, the source is actually in the discharge summary, which has already been recorded, right? So the only way we want to improve in capturing those data and extracting those data is improving the quality of our discharge summaries. What are those information that the doctors must document so that we can capture it, but also it reduces a lot of secondary data collection, which what we face when it comes to registry. You have to look back at the notes, transfer it into the registry, into the system, and then you start to analyze it. So we were trying to actually capture the information from the source and avoid that duplication of work of transferring the data into another data collection system like a registry system. And once that data has been structured, we can also push it into different platforms, visualization platform. One of them is our GIS. We use Esri or ArcGIS for that. So as long as the data is supplied with a geolocation, we can actually push that data into multiple visualization platform. And we save a lot of time to doing it. Okay, so maybe one of your question would be, oh, the color is not right. But anyway, probably your question now is how does MyHarmony do it, right? So here is an example of our discharge summary, a blob of text. Some hospitals would probably have, presenting illness, subheadings, but majority of the text is still unstructured. So how do we change this to this? Well, I guess you have to understand a bit what is our motivation. So our motivation is actually in a conventional. So the top part is the conventional method. Oh, the slide presentation really was off. But anyway, what we're trying to do is actually reduce the work to do multiple data entries. When it comes to registry, we always spend a lot of time to collect the data rather than analyze the data. We collect the data about years and years, analyze the data maybe 3 to 6 months, and by the time the information is out, it's reflective of what happens 2 to 3 years ago, and that's what we want. We don't want. We want it to be faster, reflecting of what we are currently experiencing. So now with MyHarmony, we can focus on single data entry at the electronic discharge summary in free text. But of course, we always have to do quality improvement check and engage our doctors on the ground to show that what they submit to us is actually very important. And if they can improve the quality of their documentation, it actually saves a lot of their time to collect data for all these cases. Right. So this is MyHarmony front page. This is how it looks like on our end, right? Simple menu. The first is how we manage the terminology. First, we upload our terminology. As you can see, this is the old version. This is the snapshot that I have. This is 2017. So we upload the terminology, and this is where we control the version. Number 2 is we upload our reference set. So reference set is the set. So here you can see this is just a ref set that caters for cardiology. And that ref set will be tagged to the version of the SNOMED CT International. Once we do that, we will also upload the data. So previously, even right now, our data is really manually uploaded. We are also thinking about how to automate this transfer of data. And when that happens is where the codification happens. The codification looks like this somehow. So if you imagine, like we have 3 different hospitals with 3 different same looking data set. Some hospitals may have different terms that they use, but actually means the same things. For example, if you look at breathlessness, right? Another hospital may have written it in, for example, in Malay, sesak nafas, or another hospital uses dyspnea. But because we have the MyHarmony, instead of if you query dyspnea, it doesn't just capture one, it would capture all 3. Because of the synonyms and the description in SNOMED CT. Similarly with heart failure, lemah jantung, and cardiac failure. So that's what we intend to do with MyHarmony, when it detects and automatically codify it. And then here's an example where that free text for diagnosis, right? For example, infective diarrhea with underlying right heart failure, fast AF. And what you can see is actually it detects that term, and usually the idea is it detects the longest term first, try to find the code for it, and then it cuts shorter. So you can see infective diarrhea with the code, heart failure with the code, fast AF. Now fast AF was not in SNOMED CT. I think it was, I forgot the term in SNOMED CT. So we had to create a synonym for it, additional description for Malaysia case. And from there is where we once that has been coded, it is now structured. And once it's that structured, we push it into our simple analytical tool to create the numbers and show us the with different dimensions. So we can actually play around with ethnicity, age range, because our data is very granular, individual patient, right? So we can play around with that and produce this kind of reports. So every month, if they need to, if they submit the data, we run it, and then they can get the data every month instead of waiting for another 1 or 2 years. Right. So that's for cardiology. We did similar thing for dentistry. So dentistry, we take a little bit of a different approach. Dentistry, we implemented in a system called e-reporting. E-reporting is also a secondary data collection system. There's some structured data and unstructured data. That unstructured data goes into Malaysian Health Data Warehouse, into MyHarmony, being coded automatically. Right? Once it is coded, it goes together with all the other structured data. And once it's now structured, then you can provide a table, charts, and so forth. So similar approach, but different domains. We also did mapping for our laboratory information system. For laboratory information system, we not only use SNOMED CT, but also LOINC. And in this case, the LOINC is being used for the observables. And if we run this, we save this data set and we run this for SNOMED CT, then those interpretations will be coded with SNOMED CT. And if you want to query it, then we can say that, okay, for people with troponin T positive, how many of those are, positive and negative and so forth. And I think that's it from me. Any last word? Well, I think my topic talks about begin with the end in mind. So when we started, we already know that we want to go towards for data analytics, and then we just charted what are the steps needed for it. So I hope this has been helpful. And for future collaboration, I'm happy to hear from your input. Thank you.
Thank you. Questions?
Kim Fong from U.S. National Library of Medicine. Thank you, Ismat, for the interesting presentation. So my question is around your strategy of secondary data collection, which means that you basically harmonize the primary data sources and then encode them in SNOMED, right? I was wondering whether you would have to deal with data that is already encoded in another coding system like ICD, and how do you deal with particularly data that is originally encoded in ICD? Do you map them, and do you have challenges there?
We try to separate the purpose for ICD and SNOMED. So for ICD, we know it's a classification. And because ICD is really being used even to report to WHO, so we try to make sure that whatever diagnosis that's being recorded at the hospitals are straight away being coded into ICD. ICD-10, or right now we've actually implemented ICD-11 starting January 1st. So our system now has totally changed from ICD-10 to 11. But having said that, that is for reporting purposes or using ICD. But on the other hand, we also make sure that when they send the data to us, they don't just send the ICD code, but they also send in the text, the diagnosis text. So from that diagnosis text is where we can actually apply SNOMED CT. We don't try to map it again to ICD, but we try to do whatever we can, because we know, ICD is classification. There will be, you will lose some granularity when you use ICD. So we don't try to map it, but we try to use that the SNOMED CT coded itself. For additional reportings and monitoring.
Isma, I'm going to share a personal reflection with you, which I don't think ends up in a question, but it's a sort of comment on how time changes. So in a year before you were born, in 1970, when I was 18, I joined a program that was jointly managed and funded by WHO and the Malaysian Department of Health. And as an 18-year-old, I used to drive around the kampongs around Kuala Kangsar and Kuala Terengganu, visiting the health centers and collecting the kind of data that you're describing, but very superficially, with no medical knowledge at all. And I did it together with a series of Peace Corps volunteers who had come from the United States because they didn't want to fight in Vietnam. And we, of course, had a wonderful time. I have no idea whether we contributed to the health knowledge of Malaysia or not. We may have done, I think, a little bit. But what I think is astonishing is that in one generation, in one lifetime, we moved from me running around in an old 250cc Royal Enfield collecting data with a pen and ink and a form to what you're doing, which is extraordinary and which is very likely to change the way that people think about their health, how they engage with health systems and so on. So I suppose just thinking about one maybe question that comes out of that experience is, I think we did all of that work with no patient participation at all. People had no idea what we were doing. We were just big white guys running around, with pieces of paper. And now you have a system where you could engage and probably do engage the ordinary person in their own data using MyHarmony and the My Personal records and so on. So how is that going? Do people in Malaysia begin to think differently about their own health and how the system works for them?
This is very interesting because when I present about Health Informatics Center, how we have progressed, we always actually talk about that visit by WHO to create a unit. Before we became Health Informatics Center, it was a unit called IDS, Information and Documentation of standards. So that was actually the founding initiative for Health Information Management System. But of course, the data collection process is totally different than what I'm showing with you now. Now, when we collect data, it updates every night, basically from the hospital side, when everyone is asleep, or at least not the hospital, but after 12 at night, the data straight away into our system. So within 2 to 3 days, you can run the analysis. In fact, if the parliament wants to ask questions, we used to actually give a timeline of 7 to 14 days to actually produce a report, whereas now they can ask in the morning and we can actually give the data in the evening. Right, so that's the process, kind of the improvement process. I like to share that with you, so because you did contribute.
I did have a change.
Yeah. It comes to sharing that information, or how does this actually help in terms of patient participation, or at least the citizens? We actually have a website now called KKM now, KKM for Minister of Health. It used to be COVID now, because the time of COVID, and people will start to, try to get information about COVID and what's the status, what is our ICU utilization, how are we, breaking down and so forth. But now we've changed that website into KKM now to show more information about the healthcare status. We actually do monitor the engagement, but so far, I think, of course, not so much on the citizens or the people, but the general, for example, universities, researchers, that is outside of Ministry of Health, even students, so they know what data is available in Ministry of Health, and we do encourage people to come and use the data that we have. I mean, what's the point of collecting data? We just want to keep it, right? So we always encourage people to use the data that we have. Even we've helped a lot of our masters, public health master student, because they only have 1 to 2 years of study, but they need to do research. So it's like, go ahead, use the secondary data, and then discover what you need to discover and share to the world.
Thank you very much.
Well, while you think, I have a question for you, because I genuinely don't know the answer to this. So where you're looking at dentistry, in the international release, we produce a number of dental reference sets. Do you use ours, or do you create your own?
Actually, the team, the person, Dr. Zul, I have to credit him because he is actually representing us in the dentistry CRG. So whatever development or terms, actually we have actually informed the CRG so that there are new terms that was being updated there. So I guess we are in line with what has been published in the dental register CRG with what we have now.
Okay, and a slightly different question. So you and I have known each other since 2012 when Malaysia joined, going way back. So I have a question for you and Professor Park. You better listen because I'm going to ask you the same question in a minute. You've obviously gone quite a journey with eHarmony, which I know and you and I have talked about over a long time. So I suppose one simple thing is, was the journey worth it? And I'm assuming you're going to say yes to that one, because if you're not coming back. All right. But the other question is a bit more serious, or more serious focus. If you could do something different to make things better from your experience, what would you have done differently?
One of them, I think I shared with you about the clinical engagement, not to let those clinicians, not know what you're doing and how it impact them. Number two, I think is even though we can use MyHarmony, we are using MyHarmony at the back end once the data is being stored at the national level. I would prefer that it is being implemented at the hospital itself, which is closer and you can monitor the quality of the documentation on the ground. And you can even use MyHarmony to automate the coding at the front end. It's just a matter of, performance issues of the system. So I've seen tools like Clinithink and all that. So it's quite similar. And it can be improved much better if we can implement this at the front end so that we can have the source of that information is of high quality before it reaches to us.
Okay. Oh God, we'll do a follow. I'll come back to you in a second. Do a follow-up question, and Ismat can sit down.
Thanks, Ian. And thanks, Ismat. That was a really fascinating presentation. I was very intrigued by your use of the international patient summary. Are you using HL7 CDA or HL7 Fire to put the?
We're using HL7 Fire. Yeah, but then well, there's no but we just use it for now. But now that we know that we have about 31,000 patients, we could, really look into it in terms of how we can utilize that information, like as a research or going back.
Yeah, that's fascinating. Just to follow up, have you added any sections to the international patient summary, or have you used the vanilla implementation guide?
Yeah, I think we just use what we have at the moment. It's quick. We just want to see whether can it be done. Is it useful? And I think if there's an expansion to it, I think that can be done later because we only implemented this year, and the pilgrimage is around in August.
So you used it this year in August. That's fantastic. Thanks very much.
Any other questions for Ismat first? So I think we should thank Ismat. Going back, so Professor Park, you don't get away with it. So I know you've obviously, you haven't gone down quite as long a journey as Malaysia, but looking back on where you've gone so far, is there anything, lessons learned, if you like, things that you would have done differently or you think you could have done better?
Yes, it's true that we haven't gone that far, so I have never thought about that, but looking backward, I think we could have, we actually spent a lot of time. I would say we even wasted time at the beginning of the task force because we were not aware where we're going. We wanted to create a registry. So we had a long discussion where we should start, and then standardizing the terminology was a good start, and we discussed over it, but we should have started by standardizing the terminology. I think we wasted about 6 months finding out what we should do first.
Okay, that's definitely for us, that's an implementation issue. You two down there. So do we have any other questions? Okay, so in which case, my final remarks. One, I found it really informative, and particularly with Malaysia, I know some of this, and I still found things that I didn't know about Malaysia. So I'm sure you've all found it very informative. In terms of going forwards, as I said at the start, all the sessions that we run here, we occasionally do them on camera. We haven't done it on camera this time, but we have recorded the session. We'll post the links so you can have access to the slides, you can have access to the recording after the event. Please use the link and go and have a look at some of the previous sessions. I haven't, for a whole variety of reasons that I won't bore you with, we haven't done some interim clinical webinars. I'm looking at changing that. So look out for social, let's start again, I'll put my teeth in. Look out for social media posts. But there will be some clinical webinars coming up where you can join, and we'll not link to SNOMED events. There'll be interim ones, and we'll look at doing some sessions in between. The sessions will be clinically focused. So this isn't about, learning about SNOMED in general. This will be very specific about how SNOMED's used in particular clinical domains and in real life instances, if you like. So just keep an eye open for those. So I'm going to wind this session up. So I'd like to thank both presenters, and I think we should thank them in the normal way. And I'd like to thank you all for attending, and hopefully you've enjoyed it. So if you've enjoyed it, please come back and tell your friends. Thank you.